Before we go to the ultrasound of scrotum, testicles, and other structures in the scrotum, let's see the anatomy. Scrotum is skin covered pouch suspended outside the abdominal cavity. It contains the testes, epididymis, and lower part of the spermatic cord. Here we have a testicle. You can see it is in a pouch. The head of epididymis, body, and tail, and then is the spermatic cord. Whereas in this scan, we can see a fetal scrotum with two testicles and cut section of the penis. And here you can see the pouch in the amniotic fluid. The normal testicles appear homogeneous, white, which are symmetrical bilaterally. They are homogeneously ovoid in shape. When we compare its echogenicity with the thyroid is relatively hyperechoic. This is the right lobe, left lobe of thyroid with the isthmus and trachea here. These are the carotid vessels. Then here are the muscles of neck. And when we compare the echogenicity or echotexture of thyroid with testicles will be relatively hypoechoic. The layers of the scrotum includes from outer to inside various layers of scrotum around testicles, which include fat-free skin, tarsus muscle in the superficial fascia, external spermatic fascia, cremaster muscle in the cremasteric fascia, internal spermatic fascia. Then comes the three tunica layers, tunica vaginalis, tunica albuginea, tunica vasculosa, and then comes the testes. Here are these layers. You can see the skin, superficial fascia. Then we have the external spermatic fascia. This is the cremasteric muscle and fascia, internal spermatic fascia. So the cremasteric muscle is having a outer layer of fascia which is called external spermatic fascia, and the inner fascia is internal spermatic fascia. Then is the brighter layer of tunica vaginalis. Then is the visceral layer of tunica vaginalis, and inside of this blue line is the tunica albuginea of testes. This is the sinus of the epididymis. This is epididymis. All of this is the sinus. Here we have got ductus deferens in the cut section, rete testis, in mediastinum testis. These are the septas inside. Then we have this scrotal septum. And lobules of the testes, which are separated by septa. Tunica vaginalis is a serous sac having two layers, a visceral layer attached to the surface of the testes. This is the inner side. Visceral layer attached to the surface of the testes and a partial layer attached to the scrotal wall on this side. Each testis is able to move in the scrotum because of 1 to 2 mm of fluid interposed between two layers of the tunica, tunica vaginalis, having about 1 to 2 mm. This anechoic area is the fluid in the tunica vaginalis, which has got a visceral layer towards testes and a parietal layers towards the wall. Rete testes. Numerous thin septations arise from visceral layer of tunica vaginalis to form 250 to 400 cone-shaped lobules containing seminiferous tubules. So here you can see the tunica vaginalis, the scrotal cavity, tunica albuginea, the lobules, here is the rete testes. These are thin septations arising from the visceral layer of tunica vaginalis. Here we can see again ductus deferens. This is the epididymal duct. Then we have efferent ductules and aberrant ductules, seminiferous tubules, these are the tubules. Then is tunica albuginea. These testes are surrounded by a fibrous capsule, tunica albuginea. It forms a thick longitudinal ridge, the mediastinum, which is traversed by blood and lymph vessels and also by rete testes. The mediastinum appears as a peripherally located and elongated hyperechoic structure. Here it is longitudinally and transversely. This is called mediastinum of the testicles, this hyperechoic band-like structure in the testes. Here you can see right testicle, left testicle, longitudinal and transverse. Then is the epididymis. Epididymis is tortuous tubular structure that runs along the posterior lateral aspect of testes. There is the head. It is divided into head, body, and tail. Head, body, and tail. Epididymis is approximately 6 to 7 centimeters long. The diameter of head is 7 to 8 mm and diameter of tail is 1 to 2 mm. Epididymal head, which is here. Head is located next to the upper pole of the testes. This is the upper pole and lower pole, and receives efferent ductules. These are the efferent ductules. Body and tail are composed primarily of the ductus epididymis, which is formed by convergence of efferent ductules. The vas deferens leaves epididymis from tail and runs up the spermatic cord. This is the head of epididymis and body. Here you can see the head and then body. Spermatic cord. It is the bundle of structures that extends superiorly from the testes to inguinal canal. It constitutes ductus deferens and blood vessels. Ductus deferens, which carries sperms from testes to seminal vesicles and so form the ejaculatory duct which enters the urethra. Blood vessels, which include the ductus deferens, testicular artery, and pumpiniform plexus of veins. Then comes appendix testes, and we can have appendix epididymis, two embryological remnants measuring a few millimeters each are occasionally visualized when the testis is surrounded by fluid. We can have appendix of testes and appendix of head of epididymis. This is a head of epididymis and appendix. Here is testicle and appendix. So one at the upper pole of the testes is called appendix testis. It is Mullerian duct remnant. And one at the head of epididymis is called appendix epididymis. It is Wolffian duct remnant. The size of testes is approximately length is 4 to 5 centimeters in average patients. In adults, the depth is 2 to 2.5 centimeters, width is 2 to 3 centimeters, and volume is 15 to 20 ml. Testicular size decreases with advancing age. Slight size difference between both testes is normal. This is the testicle, the length and depth. This is width. Longitudinal scan, transverse scan. So when we take longitudinal section of the testicle, we can measure the length and depth. And then we take a transverse at the maximum area, the maximum width, we measure the width in this direction. Probe handling techniques. Sonography is the primary modality to image scrotum. Patients are usually examined in supine position. A towel can be draped between the thighs under the scrotum. Another towel is placed over the penis. Warm gel should always be used, as cold gel may elicit a cremasteric response resulting in scrotal thickening, thus making the scan difficult. Probe handling. We can have longitudinal scanning. To begin with, put the probe longitudinally at the mid of the right testicle. Move the probe medially, then from medial edge side to the lateral. So we put it longitudinally, then we move medially and then go laterally again. This is the mid-longitudinal section. Then we have the medial and lateral longitudinal sections. For transverse examination, put the probe transversely at the mid of the right testicle first. Move it superiorly. We put it at the mid. The head of the transducer will be outwards. We move superiorly, then we come back to the center, to the mid of the testicle, and then we move inferiorly. So we scan all edges. This is the mid, inferior, and superior of the testicle. Indications for scrotal ultrasound. We can scan the patient for scrotal swellings like trauma, inflammation, torsion, mass, hernias, and hydrocele. When there is a trophy or testicles are small, searching for occult neoplasm in cases of retroperitoneal or mediastinal lymphadenopathy. Search for metastatic regions, localization of undescended testicles, and infertility. In case of atrophy of testes, it may be congenital or acquired in association with multiple disorders such as mumps, senility, prolonged hyperpyrexia, hepatic cirrhosis, hypothyroidism, and estrogen therapy. At ultrasound, testicular atrophy is labeled when one testis is significantly smaller than other or when it is less than 3 centimeters in length and 2 centimeters in transverse diameter. Here we can see small testicle with the hydrocele. The size is small. Here again you can see undescended testicle. Cryptorchidism, which is undescended testes, it is the rest of descent of testes somewhere in the normal path. Testes descend from the region of the kidneys to scrotum retroperitoneally along with the processus vaginalis through inguinal canal by about 28 weeks of intrauterine life. Cryptorchidism, 80% undescended testes are located within inguinal canal and are easily visualized at sonography. Intra-abdominal testes occur in the retroperitoneal from the level of the kidney to internal inguinal ring. These are the areas where we can find for abdominal testicles, inguinal, the prescrotal, which is prepubic on the side, and then is the normal position, the scrotum. So we can find undescended testicles at these 3 levels. One is the prescrotal, which is prepubic, inguinal, and abdominal. Here is a 13 days old child, the right undescended testicles. This is the right undescended testicle, the left testicle, and right is undescended, is not visible in the scrotum, whereas it is lying above near to the pubis. In inguinal canal, left testicle, right is in the scrotum, left is not visible, which is lying in the left inguinal canal. Right testicle in inguinal canal. So you can see it is the prepubic place. Scrotal lesions can be cystic lesions or solid lesions. In cystic lesions, we can have testicular or extratesticular lesions. In solid lesions, we can have testicular and extratesticular also. The extratesticular are cystic scrotal lesions, which include spermatocele, epididymal cyst, hydrocele, funiculocele, varicoceles, gynoscrotal hernia, scrotal wart edema. Spermatoceles, it is a unilocular retention cyst derived from some portion of the sperm conducting mechanism of epididymis. It is a spermatic cord. Its part or portion is showing a cyst. A blocked vas deferens, either congenital, traumatic, or inflammatory, is most likely cause. Here you can see the head of epididymis, and on this area is a cyst. This is the cystic lesions seen in the head of the epididymis are filled with spermatozoa containing fluid. Low-level echoes and thin septations are seen at sonography when gain is increased. Whereas this is epididymal cyst, which can be due to trauma, contain serous fluid and are seen within the head, body, and tail of epididymis. At sonography, these are undistinguished from spermatocele except internal echoes. This is epididymal head cyst. This is epididymis, and on left side in epididymis there is cyst. If this cyst is lying within the epididymis, it will be epididymal cyst, but if it is lying here at the periphery, it will be the spermatic cord cyst. Hydrocele is Abnormal accumulation of fluid in the potential space of tunica vaginalis. Most of large hydrocele are idiopathic. However, a variety of conditions, including scrotal inflammatory processes, testicular torsion, and testicular tumors, can cause small to moderate hydroceles. This is the normal testicle, and here you can see the fluid in the tunica vaginalis. Sphere hydrocele with internal echoes, which can be pus. When it is pus, it is pyocele. So internal echoes are there, and here is an appendix of the testes with the upper pole. It's another fluid. Some cases of hydrocele. Septation in the hydrocele, which indicates chronic hydrocele, which can be due to tuberculosis or any chronic disease. So mostly it is serous fluid, maybe the blood like hematoceles or pus, which is pyocele. Crystals can precipitate in hydrocele fluid and produce mobile low-level reflectors. These are the internal echoes, which can be debris. Funiculocele, rarely hydrocele fluid may accumulate in spermatic cord in a non-obliterated portion of tunica vaginalis. This type of hydrocele will appear superior to testes and is referred to as funiculocele or a hydrocele of cord. It is to be differentiated from a spermatocele. It does not arise from epididymis. So it will be separate funiculocele. It is not attached to the epididymis, lying aside. Varicoceles are dilatation and tortuosity of peritesticular veins, that is pampiniform plexus in spermatic cord. So grayscale sonography depicts varicoceles as numerous dilated tortuous tubular channels in the peritesticular tissues. When we put on color, we will find these cystic areas are the vessels. They are usually located lateral posterior and or superior to testes. The upper limit of normal for caliber of scrotal venous channel is 2 mm. Here are in the groin, we have vessels. These are the varicoceles, dilated vessels. Here we have a scrotum, testicle, rete testes, and dilated vessels. Here again, with Valsalva maneuver in supine or making the patient upright, the incompetent valves in spermatic veins allow rapid retrograde blood flow in the pampiniform plexus and so accentuate the varicoceles appearance. Doppler will show flow augmentation and reversal in direction with Valsalva. This is the normal and with Valsalva. Here we can see with Valsalva it is dilated. Scrotal hernia. In fetus, there is connection between abdomen and scrotal sac by a tubular extension of peritoneal cavity, and this is known as processus vaginalis. Tunica vaginalis is distal end of processus vaginalis. This connection may persist, allowing abdominal contents such as gut to descend into the scrotum. So then we can get some herniation. These are the intestinal loops with cuff. Without cuff, it was not coming. This is the herniated loop. Here you can see whole of it. Here is the testicle, and it is coming in the scrotum. So testicular hernia, the intestinal loops, especially with cuff or with standing, they are descending into the scrotum. We can have scrotal wall hernia, which is thickening. It can be due to trauma or some acute inflammation. This is edematous skin, excessive edema of the skin. Intratesticular cystic lesions are simple testicular cysts of tunic albuginea, testicular ectasia of rete testis, hematoma, and abscess complex cysts. The simple testicular cyst may be intraparenchymal or within tunic albuginea. These are common in elderly. Here you can see the rete testis, and near to it there is a cyst lying in the testes. Then is a tubular ectasia of the rete testis. This is the rete testis which is hyperaquic, and in atrasia we will miss or we will not find this hyperaquic area, or it will be irregular and it will be distorted. This is a patient with 35 years old, left side. There is some heterogeneously hypoaquic area instead of hyperaquic rete testis. Here you can see the close view. The complex cyst may contain intraluminal internal echogenicity or may have some solid components, thick walls, and we can get the internal vascularity also. The solid scrotal lesions include germ cell tumors, stromal cell tumors, metastatic lesions, extratesticular neoplasm of spermatic cord and epididymis. The testicular neoplasms are 90% of testicular tumors are of germ cell origin, like seminomas, embryonal cell carcinoma, and teratomas. 5% are of specialized gonadal stromal origin, like Leydig cell, Sertoli, and Thika cell tumors. 5% are secondary malignant tumors like lymphoma and leukemia. Extratesticular neoplasms, 90% of these originate from the spermatic cord and 70% of them are benign. Epididymal masses are rare. Patients with testicular neoplasms usually present with a palpable testicular nodule, and on ultrasound we can find it. Similarly, we can have testicular microlithiasis, in which we can get formation of concretions within the lumen of the seminiferous tubules is called testicular microlithiasis. Classical testicular microlithiasis is the presence of 5 or more microliths. Classical microlithiasis is a risk factor for the development of tumor in future. These are the small microscopic microlithiasis, not microscopic, they are very small and they are visible on ultrasound. There it is again. Testicular neoplasm, this is the normal testicle and here is a mass. They are usually hypoequic, although heterogeneity of echogenicity is frequently observed. Color Doppler plays a complementary role. Degree of vascularity can be assessed. Tumor less than 1.5 centimeter tends to be hypovascular. The seminomas are the most common single cell type germ cell tumors in adult males. Seminomas are highly sensitive to irradiation and carry a good prognosis. These are the seminomas, large mass covering almost whole of the testicle. The blood flow, it will be having heavy blood flow, gauge vessels. Mixed germ cell tumors, which includes The combination of seminomas, teratomas, embryonal cell carcinomas, and choriocarcinomas, they are usually heterogeneous and often have calcification and cystic elements. Cysts are a common characteristic of teratoma. Microerythriasis may also be seen in remainder of the testicles. There is a mass germ cell tumor. Here again, you can see whole of this is mass. Multiple sonographic presentations having nodular appearance of whole of this mass. This is another mass. We can also have metastatic lesions in patients over 50 years of age. Metastatic lesions of testes are common than primary lesions. Leukemia and lymphoma are most frequent metastatic lesions. On color Doppler, we can find it. This is a metastatic lesion. We can have some of the testicular lesions which are mimicking tumors like focal orchitis. Inflammation is orchitis. So if it is focal, it looks like mass, or it can be misinterpreted as metastasis, focal atrophy, fibrosis, infarcts, abscess, hematomas, contusions, sarcoid, tuberculosis, adrenal rest tissue, accessory adrenal tissues. In acute scrotum, sudden painful swelling of the scrotum and its contents is termed as acute scrotum. The causes are epididymitis, epididymoorchitis, which means the inflammation of epididymis is epididymitis. Inflammation of epididymis and testes is the epididymoorchitis. Then is the torsion of testes, trauma, strangulated inguinoscrotal hernia, torsion of appendix testes or appendix epididymis. Whereas the uncommon causes of acute scrotum are acute hydrocele, hematocele, hemorrhage, or infarction in a testicular nucleus. In trauma, we can get the rupture of the testicles. Testes will be heterogeneous with irregular margins and a large hematocele. We can find this is a line which is indicating the rupture due to trauma. There will be history of trauma. There is some blood. Whole of the testicle is looking heterogeneous. In torsion, it is twist of spermatic cord or testes on its attachment. It is due to faulty attachment of testes to scrotal wall. This is the normal and bell clapper sign. It is not properly attached. Tunica vaginalis envelops the testes completely, even along posterior wall. Then testicle is only attached to spermatic cord and is freely suspended in the scrotal sac like clapper in the bell and is more prone to have torsion. It is called bell clapper deformity. Hemodynamics of the torsion. First hemodynamic consequence of testicular torsion is venous obstruction, followed by obstruction of the arteries, arterial inflow, and testicular ischemia. The viability of testes depends on duration of torsion as well as on number of twists of spermatic cord. Infarction can occur within 4 to 24 hours. So acute torsion is when it is below 24 hours, subacute is 1 to 10 days, and chronic is 10 days or above. This is a case of acute torsion on this side, subacute. The scrotal inflammatory disease includes orchitis, epididymoorchitis, or just epididymitis. These are the inflammations. Here you can see the epididymis is inflamed. This is hydrocele with septa, indicating the chronic hydrocele. enlarged epididymis, then cystic structure in the testicle, the scrotal wall edema. So patient having scrotal wall edema, acute epididymitis, testicular cyst, and chronic hydrocele. Epididymoarchitis, in which we will get inflammation of the epididymis. On Doppler, it will be showing flow. The testicular size will be larger than normal. The scrotal wall thickening will be above 8 mm, with reactive hydrocele may also be visible. There is a chronic hydrocele septation with testicular swelling. Epididymitis, the testicle is normal. Epididymis is showing swelling. This is the inflammation, epididymitis. Orchitis is swelling of the inflammation of the testicles. Here it is on power Doppler. We can assess the vascularity on spectral Doppler also.